Today in the United States, there are two commonly performed bariatric surgical procedures. There's the sleeve gastrectomy and there's the gastric bypass. Between these two, the gastric bypass is often understood, or it's commonly perceived, to be a malabsorptive operation, meaning that the gastric bypass is thought to reduce the natural absorption of food and nutrients. That idea of malabsorption has an excellent pedigree, but it turns out to be incorrect. And that's important because reasonable people who are thinking about bariatric surgery for their weight and their health would have kind of a disincentive for malabsorption unless it's absolutely necessary to get the weight down. Now, just by way of comparison, I'm going to point out a less common operation called the duodenal switch, which does involve malabsorption by design because of the way the food is routed down here, and there's only a little bit of connection of the food or mixing of the food with digestive juices just before it enters the colon. And in this operation, by design, there is reduced absorption. Now, even the duodenal switch is undergoing evolution. That's a topic for a different video, perhaps. But we're mainly going to talk about gastric bypass here today. Now, first of all, just to be complete and accurate, I will tell you that both the sleeve and the gastric bypass do reduce absorption of iron and B12. These are natural minerals, and maybe some other vitamins as well. And so if you are someone who is contemplating these operations or already had one of them, it really is important for you to take multivitamins plus B12, usually also iron, for the long run, daily for life, and to follow up with your bariatric team. The idea of malabsorption usually refers to this idea that you don't absorb all of your normal protein, or you don't absorb healthy fats, or you don't absorb medicines. And I'm here to tell you that the gastric bypass does absorb all of these healthy resources in a natural way. How do we know this? Well, we know this because of what happens when there actually is malabsorption, and it's a little bit obnoxious to talk about, but when there's malabsorption, people have ugly bowel movements. And what happens is that when there's malabsorption, a lot of the normal nutrients pass through the intestine and into the colon without being appropriately digested. So there is an unusually large load of nutrients entering the colon. And the next thing for you to know is that there are billions and millions of bacteria that live in the colon. And if a lot of nutrients hit the colon, then those bacteria will go crazy on that excess nutrition, which is great for them, but it's not so good for the person that's carrying this whole situation. Because what happens when the bacteria go crazy with extra nutrients, malabsorption, is that people have, first of all, they have foul, ugly gas. Second, they have frequent, urgent bowel movements. They can't stop them. And then they have things like they have a fat ring in the toilet bowl. And in fact, the gastric bypass, just as a way of demonstrating that it has normal absorption, the gastric bypass people normally run towards a little bit on the constipated side. People have normal or less active bowel movements in comparison to pre-gastric bypass, and certainly in comparison to the malabsorptive situation like a duodenal switch, where people have frequent, obnoxious bowel movements. Now, there have been multiple operations over time that were designed to be malabsorptive, where we can see this malabsorptive principle at work. Very early in the 1970s, there was an operation called the jejunal-ileal bypass, and that didn't have any stomach surgery. It just involved rerouting the small intestine to reduce the mixing of food and digestive juices so that absorption was decreased. People could still eat a normal amount of food. They lost a lot of weight, but there were complications with that. People actually often had liver failure or kidney failure as side effects of the malabsorption and the serious absorption of vitamins, serious lack of absorption of vitamins. Later came the duodenal switch, which is a safe operation, but it does involve malabsorption, and it's gone through several modifications over time, especially in the last few years. It does involve malabsorption, and so people eat less food, they absorb less food, and typically they do have frequent kind of obnoxious bowel movements demonstrating the malabsorptive scenario. And again, gastric bypass patients have normal bowel movements, and research studies have been done, not that we want to do these research studies, but research studies have been done comparing the contents of the stool, that's the actual physical bowel movements, for gastric bypass patients versus normal non-surgical volunteers, and the contents of the bowel movements are the same, meaning there are not any leftover nutrients escaping from the bowel or escaping from the small intestine in the gastric bypass. This video is about the most common version of the gastric bypass, where there is plenty of mixing with food and digestive juices, normal absorption of macronutrients, that's the proteins and the healthy fats, and normal bowel movements. There are versions of the gastric bypass, which are minority versions, where the intestine is intentionally rerouted to reduce absorption in a way that is similar to the duodenal switch or the jejunal ileal bypass. Those modified gastric bypass operations go under names like mini gastric bypass or one anastomosis gastric bypass. And even inside the family of one anastomosis gastric bypass or mini bypass, there are many non-standardized variations, and so you may or may not have a malabsorptive situation with those operations. But the vast majority of gastric bypass operations done in the U.S. have normal absorption. Now, having established that, let me talk about where this idea came from, this malabsorption, and it's kind of a two-step process. Interestingly, the original surgeons who wrote about how the gastric bypass worked claimed that the gastric bypass had a malabsorptive component, and they were trying to understand how the gastric bypass worked because they observed that people who healed well after the gastric bypass, say 6 months or a year and a half, ate more or less normal amounts of food, and yet these people lost a lot of weight in comparison to people who had, let's say, a banding operation or a vertical banded gastroplasty, which is an older restricting only operation. And so surgeons, trying to be scientific, divided operations into restrictive, which was the band and the vertical banded gastroplasty, and restrictive plus malabsorptive, which supposedly was the gastric bypass. But then this later research has come along showing that really the bowels are normal and absorption is normal, and that there aren't deficiencies with the gastric bypass any more so than with the vertical banded gastroplasty or even with the sleeve. And in fact, most bariatric surgeons and bariatric teams these days understand that the gastric bypass is a normally absorbing operation with reference to the macronutrients, and that just like the sleeve, we have to watch the vitamin levels, especially the iron and the B12, in the long run. So why is this idea of malabsorption still so pervasive if the academic knowledge has moved on? And that gets into a marketing story. So what happened in 2001, the FDA, the Food and Drug Administration, approved the lap band. And the lap band was new to bariatric surgery in the sense that it was a surgical device that had a manufacturer behind it that, of course, wanted to sell more lap bands. And so this was the first time that marketing really came into bariatric surgery. And the lap band manufacturer, of course, promoted the lap band as a good option with good weight loss, easy recovery, and other things along those lines. And later we learned those aren't all true, but that wasn't really the fault of the manufacturer. It took time. But the other thing that they did, of course, was they marketed against the existing surgical competition. Now, in 2001, 2002, the sleeve had not come along yet. The sleeve came along in 2005, and so the lap band marketers marketed primarily against the gastric bypass. And what they did was they cherry-picked some information that was out there in the surgical literature about the gastric bypass, looking at outcomes from the 1980s when it was all open surgery with the big old cuts with actually pretty high risk. They looked at these surgical publications that described gastric bypass as being malabsorptive. This is before the new understanding and the correct understanding had come along. And they portrayed the gastric bypass in its worst possible light. Now, there was a kernel of truth to the data, and there probably isn't anything out there that is untrue in the lap band marketing, but it's only a kernel of truth that was kind of slanted, like politics. We've all seen politics recently enough. And so this information that was out there persists as kind of a common understanding, especially on the layperson side of the equation, but still even on the medical side, nursing, medical doctors, and such. And so purpose of this video is to have one little drop in the bucket, teaching people that no, absorption of macronutrients, I'm talking about proteins, healthy fats, medicines, after the gastric bypass really is pretty normal. And just in closing, even though I'm telling you that gastric bypass absorption is normal, it is really important for you to take the vitamins that are recommended by your bariatric team. As long as you do that, and as long as you maintain follow-up, you can fully expect to have normal absorption of normal nutrients, to have excellent health, normal bowel function, and excellent weight control and excellent energy for many, many years after your operation. Stay well. Best of luck.